Dear colleagues, we would like to greet you in Armenian Eye Care Project, Ground Rounds, and Malayan Eye Care Center, and Yerevan State Medical University Department of Ophthalmology organized a small conference. My name is Nune Yehiazarian. I'm the director of Armenian Eye Care Project. And for this year, we started this educational program, which has a big interest among the neuro specialists, and we see the other opinions as well. It also helps to improve our annual educational programs, and our today's meetings will be about the retina diseases, and we will do it together with Armenian and American specialists. And from Armenia, will represent the PhD, Yerevan State Medical University Ophthalmology Department professor, director of Armenian Ophthalmological Association, and head of the Department of Retina. And from United States, we will have our dear colleagues, Ruben Grigorian, ophthalmologist, and which represents North Louisiana Eye Associates Clinic, and from Louisiana, United States, and Mehdi Epremian, which is also an ophthalmologist, and he represents Nevada Retina Consultants Clinic. And first of all, our clinical residents will represent some clinical cases which were developed with their mentors, and then we will have the discussion. And if there will be any questions, you can write your questions via Zoom platform. And now, please, Armen Vartanyan, floor is yours. First of all, I would like to greet everyone. I'm very, very glad we are having this meeting today to discuss two very, very interesting cases. Especially, I would like to greet our experts, my friends, Mehdi Epremian and Ruben Grigorian. And thank you for attending this meeting at this late hour, and you are participating in this discussion. And today we will represent, dear colleagues, two clinical cases. From our point of view, they are very, very interesting, which were diagnosed and treated in Malayan Eye Care Center, Vitreoretinal Department. And we represent you these cases, and we are expecting active discussions because the cases are very, very interesting, and they are causing a lot of questions. And first, the cases will be represented by our clinical residents, Shanti Epremian and Shahinian Mane. So first case will be represented by Shant, bilateral fungal endophthalmitis, and now we will discuss it. I would like to greet everyone and thank you for giving me this opportunity for the presentation. And my today's topic will be endogenous fungal endophthalmitis, and I will represent a clinical case. This is a patient, 59 years old, female, who was admitted to our department and by Dr. Hovakimian for diagnosis of fungal endophthalmitis. Her main complaint was worsening of her vision gradually for 1 month in both eyes, and her vision was 0.1, and on the left she was noticing only the hand movements. Here you can see her photos, and during the examination on an anterior camera we find +2 and in the retina deformations near 7 o'clock, and on the vitreous there was a pace and exudation and preretinal exudation, and in the left eye +3 inflammatory reaction in the anterior camera, and the changes in the retina on 360 degrees, and haze on the vitreous, and so we cannot see the fundus. And depending on the clinical picture and due to anamnesis of the patient, it was diagnosed, we put diagnosed endogenous fungal endophthalmitis, bilateral. Let's stop here for 1 second and let's discuss what is necessary for diagnosing endogenous fungal endophthalmitis. Number one risk factors is fungemia. What are the main risk factors for fungemia? First of all, it's going to be immunosuppression with different reasons, the long-term treatment with corticosteroids, diabetes mellitus, any broad-spectrum antibiotics, any oncological disorders, maybe COVID-19 associated fungemia, which is recently, for these 2 years, we have a lot of cases about this fungemia and endogenous fungal endophthalmitis as well. And the most frequent one is central venous catheterization, post-catheterization caused fungemia. What is the pathogenesis of fungemia? First of all, it's gastrointestinal tract. In normal microflora, there are presence of some candidas, and in some cases, they start to spread. And when we are using the intravenous catheterization, there we might have a formation of fungal infection, and so they can penetrate into other parts as well. For example, in urinary tract and going upper, they can spread and they can lead to the issues. And now let's come back to our case. In anamnesis vitae of the patient, it was very, very important that 2 months ago she was hospitalized with the diagnosis of bilateral ureteric stones, and she underwent a stent procedure of on left side. And from 1 month later, she started to have the same complainings, and she once more admitted to the hospital. She was diagnosed right-sided pyelonephrosis, and there was a right urethral stenting provided. At the same time, she was diagnosed COVID-19 pneumonia, and for all above mentioned, it was mentioned in her papers that it should be excluded or approved the fungemia or bacteremia, but unfortunately she didn't underwent any other analysis. She get therapy in the hospital. She used corticosteroids for COVID-19 pneumonia, wide-spectrum antibacterials, and antifungals as well. So we can see that the risk factor, she has use of corticosteroids. She also has diabetes mellitus and use of broad-spectrum antibiotics and COVID-19 associated pneumonia. So she has 4 risk factors. And of course, the mechanism which can lead to the manifestation of fungemia was localized issues in her urinary tract candidas. So because as a response in her urine, there was a lot of candidas there. So as she was diagnosed endogenous fungal endophthalmitis bilateral, we suggested urgent bilateral vitrectomy. But as soon as she had some problems with some papers, the surgery was postponed for 2 days, and 2 days later, when she came to the hospital, her vision in her right eye was decreased, and she was noticing only the hand movements, and in the left eye she was just saw some light, and we did the bilateral vitrectomy. We sent the samples to the laboratory, and intravitreal it was injected amphotericin B and vancomycin, and as well it was put a silicone oil in both eyes in vitreous. So this is some echographic pictures before the surgery. So you see the changes in the eye. On the left eye we see the premacular cyst-like infiltration, which during the surgery it became obvious they are strong conglomerates of the inflammation and fungus. And after the surgery, immediately after surgery, and the next day, she was sent to the infectionist for understanding if there is any fungemia or no. But unfortunately, in one day, she went to the 3 clinic hospitals, and she was not admitted in any of these hospitals because she don't have any papers proving that she has fungemia. In post-operatory fourth day, you see the picture of the right eye pictures. Unfortunately, we cannot have the pictures of left eye because there was edema. So it was recovered 0.1 vision. And of course, there was a paleness in her retina, but it was a little bit lower, and it became peak, and it was kind of macular edema also was there. In post-surgery 10th day, we see that the paleness is nearly gone. We have some edema, of course, but the vision was recovered up to 0.3, and in the left we see just movement of the hands. And 1 month later, we see that the vision is 0.5, and the macular edema was gone, and on the left there was a cataract, and on the post-surgical 10 or 12th day we were able to see it, and that's why we don't have any fundus pictures, but the vision recovered was still the movement of the hand on the left side. So by this, a few important things which I would like to mention about the endogenous fungal endophthalmitis. Number one is it can be hematogenically seeding of these fungs. And number one place where we might have this problem is, of course, choroid, because there is a high vascularization there. And that's why if there is some risks, and if there is any proved fungemia except the risk number one, we should also exclude endophthalmitis or chorioretinitis or prove it. Next thing, that negative responses, cultures for the fungus infection, they don't rule out the fungemia because it is very, very hard to grow this fungus in laboratory. And there is transit fungemia, such a condition in which in the blood we cannot find out the fungus. And what are our questions we would like to discuss with you? What can we do to this patient? And of course, your advices for the future follow-up of this patient. Thank you. Now let's start the discussion. Dear colleagues, dear experts, how do you think what do you think about this case? I will add just a few words in this. A few days postponing because of some paper issues. She was from Artsakh, and there were some problems with bringing some papers. So, and for the first time in my life, I saw the bilateral vitrectomy because it was worsening of the condition. And I would like to know your opinion. What do you think about this case presentations, which was presented by Shant? I would like to hear your opinion.
It was a very good presentation, and I think your management was very, very well done. I wouldn't think that I can do anything different. I'm just curious, what did the culture show? Did the culture show anything?
Well, no, the culture was negative for anything. No bacteria and no fungi.
Yeah.
And
they
culture even let the culture to grow for about 1 month. I don't know, but nothing. Nothing. It was negative for fungi.
Yeah, unfortunately, it's only 30% of the fungi cultures for fungi, they are positive in endophthalmitis case. Now, the other testing that you can consider, I don't know if it's available in Armenia, it's called polymerase chain reaction, PCR test.
It is available. It is available, but unfortunately, it is a little bit expensive, and it is not suitable for every patient.
Yeah, but I absolutely agree with your management. It's usually it's a clinical diagnosis. You don't really need to get the positive cultures, the clinical diagnosis, and your management was very well done. Very good.
I would also like to join to Ruben, and I would greet your team. You have the best management done, and some just things which you should focus on. First of all these studies which are done, you should never think of this studies like a recipe. If it's not like this, I will like this. If in the study it is mentioned that you should do like this, you should do like this. These studies are just general approaches, not for the current situations, and the physician should decide himself in this current situation which is the best solution. And Dr. Vartanyan mentioned I'll never did the bilateral vitrectomy, I'll never did also. But it doesn't mean that in these cases, if we should make some decisions to do the vitrectomy or no, we should not do it. And once I would like to greet your team, which did a very good decision, made a good decision, and you did the only right thing which you can do. And the second thing, I would like to say a few things to what Ruben told, that we physicians like data information, numbers, values, and sometimes our clinical decisions and are analytically based. But when we are coming to the endophthalmitis, my approach is like this. If I think that this is endophthalmitis, it means that this is endophthalmitis without doing any other analysis, because this is a diagnosis which you should not miss. And the third thing which I would like, and it was very, very interesting, in French they have a phrase, cherchez la femme. If you are having some situation and you cannot find the reason, search for a woman. And now, if a person has a bilateral endophthalmitis, so it is generally somewhere we have some issue. But if we cannot find it, it doesn't mean that it is not existing. And if we know about this, we should, and in this case, we for sure know that there was a place of infection, and the fung was spreading from there and coming to the eyes, and I'm nearly sure that there was some place we have an infection. And the fourth thing, when we are speaking about the endophthalmitis, especially fungal endophthalmitis, it is very, very special things in the vitreous, inflammatory things. It's like chains of pearls, necklace of pearls, and we see it with the yellow, and it's like spheric bodies. It is also very, very interesting symptom of endophthalmitis. And one more thing I would like to mention, there's yellow exudation. I had a few cases about this yellow exudations in retina, especially if they are under macula. They are causing visual disturbances, and twice I opened the retina. They are stone-like bodies, and even if you are removing them, unfortunately it doesn't help. I'm not sure how it will develop in this patient, but if there was this yellow exudations, they want them to be removed, but I don't think they should be removed. And the last thing which I would like to say, and the Dr. Vartanyan said we are invited experts. I think that this is a road which is both sides are passing, because I'm also learning new things, and today I learned that in COVID-19, post-COVID-19, there might be Fungemia. I didn't know about this, and thank you for invitation, and I know about this. We also like to thank you for very, very interesting comments for this case presentation. I would like to say that about the vitreoretinal surgeons who are doing these surgeries will understand that in this case of the stone-like exudations, and when I'm doing this fungal endophthalmitis, and when doing around 10 surgeries, if not more, and we always try to remove these membranes and do something, but it is nearly impossible. It is kind of a wooden structure, and you cannot remove this membrane. And even in severe, these are the most severe endophthalmitis, and most of them, nearly half of them, and according to our information are leading to enucleation or subatrophy of the eyes. On the left eye, I would like to mention that when we came to the retina and this conglomerate, removing this conglomerate, the whole retina and its all the part near the nerve, it was with empty vessels, and from the retina it was like kind of necrotized. And when you were trying to remove the pus or from the posterior hyaloid membrane, and on the right eye, when we remove the oil, and the left we remove the oil, and then the surgery on cataract with focal emulsification. What do you think? We should keep this patient, or it can be worsening the situation? I want to know your opinion about this.
Regarding the right eye, that you said that the visual acuity is hand motion. You need to see how reasonable it remove the oil or not, because these patients with a lot of necrosis, they can develop retinal detachment very quickly after you remove the oil. So on the right eye, it's a little bit, it's probably will be very reasonable to leave it. On the left eye, it's a different story. Patient may have a pretty decent vision after the cataract is removed. I think my approach to this will be, do you have any view of the retina through the cataract at this point?
In the left eye, no.
In the left eye, no view?
Completely mature, and it's no way to see the retina.
Well, in that case, my approach will be to remove the cataract and take a look at retina well and see what's going on there, what to expect. And if you don't see a lot of fibrous membranes, obstruction or retinal detachment, then probably will be reasonable to remove the oil. But that would be my approach.
Yes.
My approach will be like this. In this patient or in this condition, the worst thing is we have both eyes problem, but we also have a positive because we also have the same situation in both eyes. It's good and bad. I will explain now why. Because I will do like this. First of all, I will ask the patient which eye is worse. And he will say for sure the left one. So I will sacrifice the left eye. I will remove the oil and cataract. If in the left eye everything will be okay, so for sure the right eye will also be okay, and so I will remove the oil from the right eye, the better eye. If in the left we will have the problem with retina or the tisicle, so the patient will be ready that it's better not touch the right eye, and I guess emotionally and psychologically it will be better for the patient. So this is a very good approach, and the eyes are not equal, and in the right eye we don't have necrosis, and we remove the hyaloid. So there is a beginning stage of cataract. So in the right eye we are planning to remove the oil, and in the left we'll remove the oil, and there might be phthisis, and I'm afraid of ciliary damage, dysfunction of ciliary body. Because dissection, of course, will happen, but if it will lead to this dysfunction of ciliary body epithelium and its dysfunction, so there might be a tisicle in the eye. So it's very, very interesting approach, and we will start from the bad eye, and we will see what will happen. And because they are unequal situation, these eyes, so in the bad eye we might have tisicle, and she will afraid to touch her right eye. So this is but very, very interesting approach, very interesting things, and which is common for Meheriye Premier. And I didn't guess that there's that much difference. But if there is so much difference, it might be some modification in our approach. We have a good condition. There is because of the oil. So in the right side we have a better situation, and we have some few vision. It was 0.01 before the surgery. On the left we have serious problems. Inserta, we have this kind of situation. So thank you so much for your opinion. Do we have any other questions? And now we will start the second presentation, dear colleagues. So please, Mane, floor is yours. And this presentation will also be about very, very interesting case. It's not that much rare as Shant's case, but it is also interesting case, papillomavasculitis case. And she will do the presentation, and then we will start the discussion. I would like to greet dear colleagues and participants. Once more, I would like to thank for this opportunity. So today my presentation will be about papillomavasculitis, and I will represent a case report. First of all, I would like to speak about the diagnosis of papillomavasculitis. It is a rare condition. In literature, it is described as incomplete central retinal vein occlusion, but it has a few differences. Occlusion, and this pathology is mostly common in young people before 50 years of age, females, and usually they don't have any cardiovascular disease history. So it usually comes with monolateral, painless, decreasing in vision, worsening of the vision. And in the fundoscopy, we have the edema of the optic nerve, vein engorgement, and intraretinal hemorrhages. Etiopathogenesis is not clear. One of the underlying mechanisms are suggested to be, so here it suggests that there is an inflammation and edema in optic nerve, which leads to the mechanical compression of the central veins in retina and leads to the clinical manifestation. What are the risk factors? In this case, there's a systemic vascular diseases, pathologies which are common and are leading to hypercoagulation situations, systemic autoimmune diseases. There some clinical cases were presented with Guillain-Barré syndrome and papillomavasculitis. One of the risk factors is also pregnancy, use of the oral contraceptives, dehydration, and recently there were some clinical cases about COVID-19 patients having papillomavasculitis. How do we diagnose it? In diagnosis, it is very, very important the anamnestic information, laboratory and instrumental investigations. And usually these patients are presenting with visual field high numbers, but in the fundus they are having some changes, pathological changes. And we do the visual field testing. We try from the blind spot increasing, and we see the OCT, fluorescent angiography laboratory test to approve or exclude any systemic disease which can be the reason for papillomavasculitis. And we're also doing the brain and orbit imaging to exclude any tumors or any risk factors for increasing of intraocular intracranial pressure. Differential diagnosis based on the anamnesis and all these tests, we can do the differential diagnosis. We should differentiate with central vein occlusion in retina, which is common for elderly patients and is coming with cardiovascular diseases. We should differentiate it with retinal vein prethrombosis, which mostly occurs as a result of use of oral contraceptives, and the clinical picture is different based on the stopping of the drug therapy. We should also differentiate it with non-arthritic ischemic neuropathy, hypertensive retinopathy, diabetic papillopathy, and on all these pathologies we have the systemic diseases, hypertension, diabetes, which can be absent in case of papillophlebitis. We should also differentiate it with infection papillitis. Here, the laboratory test will help us to exclude the HIV and C-reactive peptide, and X-ray chest test we can differentiate it. We also should differentiate with orbital compressive lesions, papilledema, which is bilateral, in difference with papillophlebitis, and of course we should differentiate with optic neuritis, which is also very common for youngs, but in this case we have changes in vision. So what is the management strategy? As I already mentioned, the mechanisms is the edema of the optic nerve, so the treatment is provided with corticosteroids. We can do it periocularly, intravitreal, and also systemic use. And also it is important to in case of diagnosis of any other diseases, that the patient should be treated for the main disease as well, or any other comorbid situations which can cause papillophlebitis. And in some hospitals and some physicians are using in their practice antiplatelet and anticoagulation therapy, which is not proven to have this positive effect on the outcome of the disease. So now I would like to represent my case. 44 years old female, came to the Malayan Eye Center in vitreoretinal department, and she complains of problems in worsening of vision in the left eye and changes in color vision. The vision is 1 in both eyes, and we do the fundus examination, and here you can see the left fundus on left eye fundus, where you see the edema of the optic nerves and changes in the veins and dilation in the veins and intraretinal hemorrhages present there. This is the fundus examination of the right eye, which is in normal situation, and in both sides in the anterior segment and intraocular pressure was within normal ranges. So what were our further steps? She was sent to hematologist and internal medicine and rheumatologist consultation, and she underwent some tests in blood, urine test, coagulogramma, C-peptide, homocysteine test, which were within the normal ranges. In the rheumatologists, they also excluded the systemic lupus lupus, which was also excluded. In X-ray of the chest, did not find any abnormalities. The patient also was found with HLA-B51 antigens, but there was no clinical symptoms, so the rheumatologists did not put any diagnosis. But in the blood, we find out high numbers of cholesterol, especially low-density lipids, and the atherogenesis factor was higher. So as you can see from the picture, there was a high concentration of thyroid hormones and TPOA antigens. Patient was sent to endocrinologist for consultation, and she was diagnosed autoimmune hypothyroidism, Hashimoto thyroiditis, and the patient started the therapy for this. And 5 days later, she once more came to the hospital. She complains of vision disturbances, which was not corrected, and the vision was 0.08, and you can see the changes in the fundus when we have the edema. There was a macular edema as well, and there was an ischemic zone present there on the veins, and also some hemorrhages were also increased. And in this phase, it was diagnosed papillophlebitis as a possible diagnosis, and we decided to start the betamethasone injection, subtentant injections, and the patient got 2 injections. And we also prescribed eye drops 3 times daily, Nefenac 0.1%. This is a non-steroidal anti-inflammatory eye drops. And 10 days later, the patient's vision was a little bit improved, 0.3. And we see that their optic nerve edema was also decreased, and there was some macular edema, and there were some ischemic zones, there's cotton spots, and there were some hemorrhages also present there. And 1 month later was also improvement in the patient's condition. It was 0.6, 0.7. And we see that the number of hemorrhages is increased and the optic nerve has normal borders. And of course there is a presence of some ischemic zones and some hemorrhages. And we also performed the visual field test, and we find out increasing in the blind spot. And for the last visit, 3 months later, the patient was corrected 0.8 with correction, and the fundus picture is like this. We have some just small hemorrhages, but we don't have any edema near the macular part as well. And the picture was very, very good. So in this day we also performed a CT test, and which revealed no pathologies near the macular part, and the optic nerve OCT. We see this cup test discs, and we also in the peripapillar some thinning. So our present prepared some few questions according to this clinical case. What is the appropriate follow-up for this patient, on your opinion, for when we should call her to the patient to come for the next visit, and what other test you will suggest? And the second question is, could her condition be associated with her autoimmune hypothyroidism? Can this be the reason for this papillophlebitis? And my third question, what other tests you will do for the test, and what treatment tactics you will use? Thank you. What is your opinion? I think it was also a very interesting case, and we would like to know your opinion so together we can discuss what do we have, what else can we do, so in the future how we should treat these patients and how we should treat patients like this. What is your opinion?
It's a great case, guys, and you really managed it very well. The thing is, when I first saw the pictures you showed, I thought this is central retinal vein occlusion, but the response to the steroid was incredible, and all this venous tortuosity and engorgement, it's all gone away. Yeah, I agree. This is most likely was paraphlebitis. Now, I think you can assume it can be connected to the thyroiditis, but can you say it for sure? Obviously not. As you mentioned before, that some of the causes are idiopathic, so we don't know why it happens. The follow-up for this patient, I probably would follow up this patient every 3 to 4 months for the first year, and then I may extend, depends the patient, if patient is doing well. When I assume you ruled out all other inflammatory conditions like inflammatory or infectious conditions such as sarcoid, lupus, syphilis, all those main conditions that can cause these kind of findings. That's I think everything was done correctly. It's a great response, and it's actually amazing response. Yes, absolutely. Did you no cells in the vitreous at all? Did you see any cells in the vitreous?
No.
No cells. No cells. Okay.
That this is kind of idiopathic case, and we think that there might be some autoimmune inflammations. We did tests which were possible, and some tests were impossible to perform based on the social condition of the patient. But for us, this was enough when we see that vision was worsening, and after the first injection, we see that there was an improvement in her condition, and we just continue the treatment with glucocorticoids, this therapy, and with the minimal amounts, and we use just the drops, and I mean that we use anti-inflammatory drugs, and the patient was using them for 2 months, and gradually we have the improvement in her condition. It was a very, very interesting case, and we wanted to present it. So, Mr. Yepremian, what is your opinion? What else can we do which we did not perform? You did more than I will do, because if I will have this patient, I will start with the Avastin, but this is very, very interesting case which I now learned, and based on the reasons, and I see the results, and your approach was very, very right. If you are giving the injection, the steroids, and in a few days you have this kind of improvement, everything was very, very correctly performed. And the second part, what was the frequency to do the follow-up for this patient? And my approach will be like this. In case of this kind of vein-occlused patients, if we don't have any edema, I'm doing this 3 to 3. So for the first 3 months, for the three times each month, I'm calling the patient. If no edema, next 3 times 2 months frequency, and if no edema, the last 3 times 3 months, each 3 months, and then the patient can be free. And the third part, what I will do when I'm having the elderly patients with this occlusion of the veins, the main reason is their age. So the arteries are becoming more narrow, and they're doing this mechanical pressure when we are having a more young patient, and it makes us think about, and or the investigation which you already did, I will do the same. Your approach was just perfect, and I will just add one thing which we should never want to miss in young patients are having vein occlusion is cancers of blood, because some cases of leukemia, we can have these situations, and always remember about the leukemia, because sometimes the therapists do not think about these leukemias, and so you should make them think about this. In English they said this blood dyscrasia, so any worsening, any malignancies of blood, they can cause these issues. So thank you. We discussed with her physician the injection of Avastin from the first day, but for these recent years where we see this kind of cases where we have the ischemia or where we have the VHF factors, we always think about the Avastin. But we decided, as the glucocorticoid and diprospan also has this anti-VHF effects, so we just wanted to use them, and if we don't have any positive feedback, we'll do the intraocular anti-VHF injections. So we thought about this, we discussed this, and after the first injection on the next day, or a few days later, and the patient called and said that I had improvement in my conditions, and so we decided that we should continue with the each week injection. And so when we have the improvement in their vision, and we started the drops, so we decided to remove the high doses of steroids. So about the follow-up at 2 months, 3 months, it's a very, very interesting idea, and we will implement this in these patients, and we'll use your experience. You will have a bigger experience in these patients, and we don't have that much experience working with these patients, but this medical retina is not developed in our country, to be honest, but now we are working on this, and we have some positive results. So thank you very much. We also like to thank you for participations and for your opinions. Do we have any questions? Do we have any other questions? So we don't have any questions, and we would like to thank you, and I would also like to join you and thank you I'd like to thank our dear experts and our residents, and they are presenting their cases. And of course to Mr. Vartanyan, who was organizing today's meeting. Thank you, and we wish you the best. I would like to wish you a good day, because there is a morning. And for us, a good weekend, to have a nice weekend. So have a nice weekend. Goodbye. Thank you so much.